this is Tori Novak, and I am presenting my case study for clinical education for the spring semester. I took a look at my patient information. This was all found in the patient's chart. This was a male patient, 81 years old. This patient was 5 foot 8 inches tall, 96.6 kilograms, which converts to 212.5 pounds. This patient was admitted to the hospital facility on March 6th of 2020 with a do not resuscitate code. This patient's chief complaint was shortness of breath, fever, and the inability to move secretions, and the physician's admitting diagnosis was COPD. So then I looked at the clinical proof to decide if COPD exacerbation was an appropriate diagnosis. So looking at the chest x-ray, there was no signs of increased density or consolidation, and the white blood cell count was within normal limits that indicated that there was no signs of infection. So looking at the events that led this patient to admission, on the 4th of March, the patient presented to the clinic to see their primary care physician with shortness of breath, fever, cough, and the inability for them to move the secretions. So the physician saw the patient and ordered them some antibiotics, prednisone, and the duo-neb treatments to do at home. 2 days later, on Friday the 6th of March, the patient returned to the clinic, stating that their symptoms had worsened, the cough was worse, the shortness of breath was worse, and that is when the physician decided that it was time for the patient to be admitted to the hospital floor. With this, the physician ordered the duo-neb treatments 4 times daily and pulmicort treatments via nebulizer 4 times daily as well. So then I went to my patient's chart and I wanted to see my patient's history. I thought this would give me a good idea of who my patient was and what I needed to look for with this patient. So looking at their respiratory history, I saw that this patient had a history of hypoxia, COPD, and COPD exacerbation. This patient also had obstructive sleep apnea, but refused to wear the CPAP mask. This patient also had chronic bronchitis, which is very common in patients with COPD, and they had dyspnea upon exertion. This patient also was a former smoker, which could have been a comorbidity to the COPD. However, I was unable to receive information regarding pack years due to the patient's cognitive impairment from dementia. The patient was also a retired farmer, so the occupation was probably hazardous and could have also led to the COPD. Then I looked at the patient's medical and surgical history, where I learned that this patient had a history of back and knee arthritis. This patient had deafness, which could have also been caused by their occupation. They have dementia. This patient has depression, diabetes mellitus, dyspnea with exertion, hyperlipidemia, hypertension, prostate cancer, the obstructive sleep apnea, and they also had a history of lumbar fusion. So the first time that I was able to go in and assess my patient, I noticed that the patient's color and temperature to touch seemed very normal. The patient was alert and oriented and pleasantly confused. There was no accessory muscle use that I could note, as well as no edema or diaphoresis. And the patient's breathing pattern appeared to be normal with regular chest expansion. So then I looked at the vital signs. The respiratory rate bounced between 20, which is normal, and it got elevated at 24. Otherwise, that kind of was between those two numbers. The heart rate was fairly normal, around 76. The SpO2 stayed about 94% on 1 liter via nasal cannula. The patient's blood pressure was high at 163/75, but as noted previously, this patient does have some hypertension. The patient had a normal temperature at 97.4 degrees Fahrenheit, which converts to 36.3 degrees Celsius, and the patient's in and outs were normal. The assessment of this patient included breath sounds, which I noted were coarse and diminished with slight expiratory rhonchi. The diminished breath sounds are normal for a patient with COPD as long as prolonged expirations, which I did note with this patient as well. The rhonchi and coarse breath sounds could be attributed to the chronic bronchitis that this patient has, which is a common thing to see with COPD patients. This patient was also tested for both influenza A and B, where both tests came back negative. Then I looked at the lab values that were drawn on the 8th of March, which was 2 days after the patient's admission. And as you can see, almost all of the lab values were normal. The blood urea nitrogen level was 29, where they consider 20 the highest side of normal. And I did a little bit of research and noted that that can be due to diabetes. And of course, the glucose also is high, which I attributed to the diabetes mellitus as well, at 286. Looking at the chest x-ray, the first x-ray was done on admission day. It showed an elevated right hemidiaphragm, no consolidation, no pleural effusion, but it did show hyperinflated lung fields. And so there you can see the doctor's interpretation of the chest x-ray. I didn't include a picture of the chest x-ray because I was concerned that that may be a violation of HIPAA, and I didn't want to contribute to that even if I removed the patient's name and information, so I just went ahead and left that out of this case study. Looking at the connections, so I wanted to see if what we saw in the chest x-ray would lead us to a diagnosis of a COPD exacerbation, and it did. There was no signs of consolidation or increased density that might lead us to think that there was pneumonia. And the lab values, there was no high level of procalcitonin to indicate pneumonia. The lung fields were clear and hyperinflated, which is a pretty clear sign of a patient with COPD. And then we looked at the non-respiratory medications. As you can see, I listed the medications that I felt were necessary due to the fact that the cardiopulmonary system works so closely together and all the body systems interact. So I felt that it was important to know these medications and why. So this patient is on 2 different kinds of high blood pressure medication, Norvasc and Zebeda. The patient's on Lipitor for high cholesterol. I was surprised to see that this patient was on Rocephin, which is an antibiotic, because the white blood cell count was within normal limits. So that was one that did surprise me. The patient seemed to be a little bit more irritable or anxious in the night, which led to the patient not sleeping. And so they decided that it was time for the doctor to order some anxiety medications. And so Klonopin was ordered, as well as Aricept for cognition impairment. The thought that maybe the patient was feeling unfamiliar with where they were could have led to the anxiety, thus the patient not sleeping. And so that's why those medications were ordered. Also, the doctor ordered Novolog Flex Pen, which is an insulin pen for the treatment of this patient's diabetes mellitus. Then I took a look at the respiratory medications. So the doctor did order Duoneb 3 milliliters by inhalation 4 times daily. This is a bronchodilator that's used for shortness of breath. The physician also ordered Pulmicort 0.5 milligrams by inhalation via nebulizer twice daily, and this is used to reduce swelling. And then the patient was also ordered CPT in the form of Coronet to help loosen the secretions that they were unable to expectorate. So looking at patient outcomes, short term, so the last day I worked was the 9th day of March, and that was because of COVID-19 forcing my clinical site to cancel student clinicals. So at that time, I noted that the patient was much less symptomatic than they were upon admission. So I expected that the patient would probably be sent home within the next few days with the continued orders for Duoneb and Pulmicort, and also the information the patient needed to continue the CPT at home to keep loosening those secretions from the airways. Looking forward to 2 months post-discharge, I would expect that this patient is probably going to have returned to a mostly normal lifestyle. One thing that's really important for COPD patients is that they can try to pinpoint what is the trigger for their exacerbations, to avoid those things and to lessen the number of exacerbations that they experience. So I would hope that the patient was able to do that, and also that the patient was able to get their diabetes mellitus under control and to just have their overall health in a little bit better state. So then looking forward yet a little bit farther, 1 year or so post-discharge, regardless of how healthy a patient is, the disease process of COPD is something that these patients are probably going to experience ups and downs with. And so I would say that realistically, this patient will probably be hospitalized probably at minimum once within the next year. We can't treat COPD, or we can't cure COPD, but we can treat the symptoms, and we can try to avoid the triggers, and we can give these patients the information they need to live a more fruitful life. So then I looked at the patient outcomes. According to Desjardins and what I actually saw with this patient. So this patient was basically spot on to Desjardins. The only thing that I didn't see that I was sort of surprised was that this patient was not thin or underweight. This patient was pretty much of average build. I don't know what necessarily would cause that, but I suppose just the differences between people. Otherwise, all of the expected outcomes were spot on. Some final thoughts that I wanted to share. I did a lot of research on the World Health Organization, and they say that spirometry is one of the best and most cost-effective ways of being able to sort of see what type of airflow restrictions your patients might have. So I had a thought that was sort of interesting about potentially over the course of the year, when we see these COPD patients, keeping track of their spirometry volumes, seeing if their volumes are decreasing or potentially increasing to some degree over the course of the year. If they're decreasing, we can see that their disease progression is, maybe a little bit quicker. And we know that we can't reverse COPD. So we have to treat the symptoms, and we have to do whatever we can to help our patients live a more fruitful life. So one of the things that I was able to do at my time in clinical was participate in pulmonary rehab, which I feel like is an excellent option for people who experience pulmonary issues. So in pulmonary rehab, maybe when the patient begins, they can only walk 5 minutes on the treadmill, and they need 4 liters of oxygen in order to do that. And maybe by week 3, your patient can still only walk 5 minutes on the treadmill, but they're requiring less oxygen to do so. So pulmonary rehab helps these patients to be able to exert themselves with less dyspnea, which is a wonderful outcome. And I also feel that patients need to be educated properly on their disease process. There's various forms of education that are available, and I feel like we need to educate not only the patients, but their spouses and their family members. This can be regarding things such as nutrition, end-of-life care, and things that just would make their lives more simple, like spacing out physical activities or moving heavier items that they use to a lower shelf in order to not have to exert themselves as much to reach those items. So those were just kind of some thoughts I had about COPD and what we can do to help those patients. And then here's my reference page. I used Des Jardin's book as well as Egan's. And then I also used the World Health Organization website, the CDC website, and medlineplus.gov website.